Good morning, everyone. I am Nadia Fida. I'm the Advanced Heart Failure Transplant Cardiologist, and this is Christina, who's my Advanced Heart Failure and Transplant Nurse Practitioner. We are both primarily stationed at Houston Methodist Baytown and take care of our advanced heart failure patients. I'm very excited to be here with you, and together we will share with you how to take care of the advanced heart failure patients, what do we do, when to call us, and how you can partner with us in providing best outcomes to these patients. We're going to be presenting this talk together, and we will try not to bump into each other. Thank you.
So some learning objectives for today will focus on the understanding of the universal definition and staging of heart failure, recognizing when to call and involve the advanced heart failure team, some risk assessment tools, and an overview of advanced heart failure therapies that are available. So the universal definition, which was devised by the American College of Cardiology along with the Heart Failure Society of America and 14 other countries, created the universal definition, which says heart failure is a complex clinical syndrome characterized by symptoms and or signs of cardiac dysfunction, such as fatigue and or shortness of breath, that result from structural and or functional cardiac abnormalities and corroborated by elevated natriuretic peptide levels and or objective evidence of pulmonary systemic congestion. So a lot of words to basically say that it is the subjective and the objective that make the that give the diagnosis of heart failure. We classify heart failure by ejection fraction, so we've all heard of HFrEF, HF mid-range EF, and HFpEF, but we must always understand the underlying etiology. Beyond ischemia and hypertension, we're increasingly seeing heart failure due to genetic and infiltrative cardiomyopathies. And understanding these causes allows us to tailor therapies and identify reversible familial forms. So that's fine.
So there are many classification systems available in order to understand where does a patient lie in their trajectory in the continuum of heart failure. For example, the New York Heart Association classifications describes the patient's symptoms, how advanced they are in their symptoms. New York Heart Association class 4 patient would be very symptomatic, short of breath at rest, in addition to the physical activity. Then in 2001, American College of Cardiology and American Heart Association came up with stages of heart failure. Stages of heart failure describe the continuum from at-risk population to asymptomatic LV dysfunction to advanced heart failure, like in stage D patients, who would then are symptomatic despite best tolerated evidence-based therapies. The INTERMACS classification system endorsed by the Interagency Registry for Mechanical Assisted Circulation describe patients who are in advanced heart failure, but where do they lie in that continuum? Which patient has a bad prognosis, which patient needs urgent intervention. So profile 1 are the patients who are crashing and burning in your ICUs that you see them on support, either listed or being worked up for advanced heart failure therapies. The patients that are much less sicker into max class 4 to 7 are either on an inotropic therapy or not and are waiting outside of the hospital. In practicality, these classification systems are more used in tandem and in parallel to understand the disease process, to understand the prognosis, to have that conversation with the patient on when they need more than a medical therapy. The face of end-stage heart failure is nothing less than of a patient with a cancer diagnosis. These are the patients who are living their life in not a very happy place because they are very, very symptomatic. They are rapidly progressing, And we need to do our best to identify their clinical trajectory to provide the best outcomes to them. The natural history of heart failure with reduced EF is progressive. It's a progressive disease. Once you discover a patient who has an asymptomatic LV dysfunction, they will naturally progress over the span of weeks to years. They will have bumps in the roads. They will have stability in the road. The challenging part of this is that a lot of this becomes unpredictable. The unpredictability of it makes it challenging for clinical providers to understand when to refer to advanced heart failure. Who are the patients who are going to need something beyond medical therapy? Any stressor during this continuum can decompensate a very stable patient. A stable patient who is now decompensated and now is not getting stabilized is a very concerning patient. Patients who are not becoming stable and are getting recurrently hospitalized are very concerning patients. Patients who have now developed multi-organ dysfunction due to their primary cardiac etiology are concerning patients. This trajectory also helps us to understand that when is the good time to involve palliative care when we are moving beyond patients who we can help even with advanced options.
So quick question before we talk about kind of some pointers to help point out these patients. Just a quick question, which patient would y'all think needs an advanced heart failure team consult? Patient A, a 63-year-old with ischemic cardiomyopathy, this is their 4th admission in 12 months, comes in with a VT shock on ICD, or patient B, a 45-year-old with newly diagnosed non-ischemic cardiomyopathy with good social support. So quick raise of hands for A, quick raise of hands for B. So A is our guy that needs needs advanced heart failure therapies. I'm going to go to this one first and then I'll go back. So this is the mnemonic that we use, that we recommend use for clinicians and people at the bedside to say, hey, maybe this patient does need an advanced therapy, an advanced heart failure evaluation. So patients that are on inotropes, that are NYHA class 3 or 4, or they have an elevated and rising BNP, progressively rising over the course of time. They have signs of in-organ dysfunction, so elevated creatinine, elevated LFTs. Their EF is less than 35. They've had shocks from their ICD. They've had more than one hospitalization in the last 12 months. They're still edematous or symptomatic despite escalating diuretics. They have low blood pressure, and they are having progressively worsening GDMT intolerance.
So what is advanced heart failure and transplant cardiology? What do we do? Why does it matter to involve an advanced heart failure cardiologist? The subspecialty got its recognition in 2008. It was approved and endorsed by multiple boards. The workforce reality, however, is that at any given time, you have far more aging and advanced heart failure population than you're going to have subspecialists. So we look to you as the nursing is the core of what you're doing and providing care, and our other cardiology colleagues to involve us at the right time so we can help those patients when it is not too late to offer advanced therapies. So timing is everything because as you can see in this, on the left-hand side, you have patients, as we talked about, in different classification schema, how we use these classifications jointly, how these patients move from stability either to worsening or back to stability. On the right-hand side, what you see is the trajectory of patients who need either an advanced heart failure evaluation, who didn't get it, versus who got a destination therapy LVAD versus who got a transplant after that. The trajectory of these patients is progressively worse. Patients who are at an end-stage cardiomyopathy who needs advanced heart failure, the longer we delay that, the more the end organ dysfunction develops, the chances that their prognosis will remain good will become poorer and poorer.
So we've used our mnemonic, I need help. You say, hey, this patient meets this criteria. Now what do I do? So that then you would obviously involve the advanced heart failure team, or consider involving the advanced heart failure team. And then what do we do once we get that referral? So we do a heart failure review. So we check advanced labs, imaging. Sometimes we use things like cardiac MRI, cardiac PET scans, genetic testing, cardiopulmonary exercise testing, right heart cath. And we use this information in a continuum. So we continually review this information as we follow the patient to determine when would be a good time to start planning for future events, such as transplant, VAD, as well as discussing palliation, like Dr. Fida already mentioned. So again, the labs that we use, BNP, troponin, some advanced imaging, echo, MRI, PET scan, genetic testing is a big thing that we use to help identify inherited cardiomyopathies, and it gives us prognostic impact in family screening.
So to understand a patient's trajectory, beyond the classification schemes, it is very important to have an objective sense of where the patient is clinically. Tools that we use for objective assessment that Christina just mentioned. Let's talk about invasive hemodynamic assessment or right heart catheterization, or sometimes in your ICUs, we do a bedside PA catheter insertion. Why do we do that? Number one, this assessment gives us an understanding of, in very simple terms, is the patient too wet? Is the patient dry? Does the patient have low output? Does the patient have normal output with other things, or is it a combination of all of this? The catheters make us understand how are the filling pressures, how is the preload for the ventricles. It makes us understand what is the afterload, how much is the resistance each ventricle is pumping against, what is the cardiac output. Does the patient has pulmonary hypertension? Pulmonary hypertension is a very adverse marker in advanced heart failure. A pulmonary hypertension that we cannot modify or reverse can make a patient not eligible for heart transplant or an LVAD, or they may need staged RVAD, or they may need optimization of that before going in. A patient with pulmonary hypertension who has concomitant right ventricular dysfunction is more adverse prognosis. In heart failure population, in advanced heart failure population, it is a very important tool not only to diagnose but to prognosticate. Beyond diagnosis and prognosis, PA catheters have a role in guiding hemodynamic management throughout the stay of the patients if that's what they need. This is what tells us where the patient is in that trajectory, how much we can modify to make them eligible, or if they are currently listed or they're going to go to an OR for an LVAD, if we can optimize them. Another objective tool that we use for ambulatory heart failure patients is cardiopulmonary exercise testing. Cardiopulmonary exercise testing is an assessment of the patient's heart, lungs, and the muscles on how they are working together as an efficient unit to extract oxygen under exercise. This is a validated tool to understand not only the prognosis of the patient, but there is a set criteria on the parameters on when the patient meets the criteria for advanced heart failure or transplant listing. A maximum oxygen consumption of 14 index to the body size is an acceptable tool to say this patient is advanced in their trajectory and needs listing for transplant. There are other parameters that we obtain from this tool, like the ventilatory efficiency, how much the patient has to exercise to get rid of the carbon dioxide that is being produced by the exercising muscle. So a ventilatory efficiency by the carbon dioxide slope of more than 35 is a huge red flag for these patients. Then the patients who cannot produce a maximal exercise because either they are deconditioned or their hearts are too limited, we have other parameters like the oxygen uptake, efficiency slope, etc., that we use to understand where their limitation lies. So a very objective way beyond the classification system. The risk score. Why do we use risk scores? So risk scores are a way to establish, either in an outpatient setting or an inpatient setting, to understand the trajectory of the patients. There are multiple risk scores available to do this. There are outpatient risk scores like Seattle heart failure and the MAGIC risk scores. You can Google them. A calculator will pop up. They are easy to do. In the outpatient setting, they provide a long-term risk for the patient. The patients who are on medical therapy but sort of might be sliding, the patients who have devices, where does my patient, or to facilitate that discussion with the patient in the clinic when you see them, hey, this is where we are in your trajectory. For acutely ill patients, then there are other risk scores like ADHERE, which tells us the short-term risk of the patient. Then there is Intermax profile, and then for patients, for example, whom we are considering for an LVAD, we have right ventricular risk score, how their right ventricle will do. Because remember, when we do an LVAD on a patient, we are supporting the left side of the heart, but not the right side. We need to understand if that right side will be supporting the patient, or we are at a risk of immediate failure.
So this slide kind of summarizes everything we've talked about. We've talked about identifying the patient via I need help, what class and stage the patient would be in. Then we need to talk about what are the options once we've involved advanced heart failure. So typically that involves things like inotropes, MCS or mechanical circulatory support, and transplant. So the LVAD, left ventricular assist device, is typically either a bridge to transplant or destination therapy for patients. It improves survival and quality of life. Heart transplant is the gold standard for eligible end-stage heart failure patients. The median survival for that is 12 years. It does require lifelong immunosuppression and monitoring. And then palliative care and supportive care are always options for patients. They focus on symptom management and quality of life. These are things sometimes like home inotropes that we can send patients home on. They can live their lives and try to stay out of the hospital. That's the overall goal for those guys. Some absolute and relative contraindications for both VAD and transplant. So transplant, a contraindication is over 72. It's important to know that patients that are morbidly obese, there's a BMI indication for these patients as well. And a very, very big factor for these patients, aside from how they are clinically, is their social factors. So these patients need a lot of social and family support. They need to be drug, alcohol, tobacco free. And a lot of times that's the part that will trip up a patient that looks very good on paper as a candidate for a transplant. They just don't have the social support in order to help them. And so therefore they will most likely not be a candidate. And then like Dr. Fita said, fixed pulmonary hypertension that we can't augment with some other treatment measures is another contraindication for transplant. For VAD, again, we need a lot of social support for these guys as well. And age over 80 is another contraindication for them. So some take-home points: recognizing the I need help criteria early and escalating care promptly. Annual risk assessment is key. And then advanced therapies help save lives whenever they are initiated timely. Any questions? We appreciate y'all, everything y'all do for our patients.
All right, thank you guys.